Dear audience, this is Dr. Trina Islam. I warmly welcome you to all to the program on HumAn-1 trial first time in Bangladesh, organized by the Diabetic Association of Bangladesh with the collaboration of University of Pittsburgh and funded by the HumAn Charitable Trust. Today, we will explore one of the most important milestone in Bangladesh research, the randomized clinical trial on type 1 diabetes known as the HumAn-1 study, which was conducted first time in Bangladesh. This landmark study reflects our nation's growing capacity in global health research and its commitment to improving diabetes care for all. So, we are truly honored to have with us four renowned experts from home and abroad who have played key roles in this scientific journey. So, we have Dr. Bedowra Zabeen, Pediatric Endocrinologist, Director Pediatric, BADAS. We have Dr. Jing Luo, Associate Professor, University of Pittsburgh, USA, who is the Principal Investigator of the HumAn-1 trial and an advocate for affordable insulin access in low and middle income countries. We have Dr. Eimhin Ansbro, Deputy Director, Center for Global Chronic Conditions, Department of NCD Epidemiology, London School of Hygiene and Tropical Medicine, UK. And we have also AB Gil Foulds, Project Manager. Thank you so much, dear sir and madam. And we are really happy to have you today in this discussion. So, today we will talk about clinical trial discussion on type 1 diabetes, HumAn-1 study, Bangladesh, that was conducted few days back, and you are going to publish it as well. So I can start with Dr. Jing Luo. Sir, why was Bangladesh chosen for the first HumAn-1 clinical trial? Would you please explain?
Sure. When we were first deciding on where to conduct the trial, one of the questions that the sponsor had asked us was, there are so many different low and middle income country settings.
We have India beside
Yeah,
this.
exactly. Like, which ones would you go to if
Yeah.
you were given the choice?
Yes.
And so we had to ask some of our collaborators and people that we trust and people who have been doing and helping to support diabetes care at diabetes centers located in over 40 low and middle income country settings.
Yes.
And the person that we spoke with, he was a pediatric endocrinologist named Graham Ogle. Dr. Ogle, based in Sydney, had recommended a number of different countries and expert diabetes care centers.
Yeah.
And of the ones that was suggested, Bangladesh was coming out as number one among their choices. Yeah.
So throughout this trial, you were in Bangladesh?
Yes. This is my third time to Dhaka.
Oh, really?
Yeah, we first came in 2021.
Yeah.
When we were doing the site qualification visit.
Yes.
And then we did training visits as well sometime in 2022.
Yeah.
When the staff had already been hired and we needed to train them about the study procedures and also what and why and how to do some of the study procedures and tasks.
Thank you so much, Dr. Bedowra Zabeen, ma'am. Would you please explain how does this trial make Bangladesh a pioneer? And definitely it's the first trial on this topic, and many trial is ongoing in our country, and sometimes it's stopped because of many obstacles, right? And now this time you guys could completed this trial and you successfully submitted this paper as well. Please.
Thank you. Yeah, this is true. It was the first randomized control trial, we should say, in Bangladesh. And it was really a challenge, I should say, for make it happen. Because lots of issues are there also in Bangladesh as a low middle income country.
Yeah.
But again, we are blessed that we have Diabetic Association of Bangladesh, we have BADAS, and we have PDRC, that's the Pediatric Diabetes Care and Research Center, where we are giving, diabetes care for last 15 years. That is, since 2010, we started with international collaboration. And as just Dr. Zing mentioned about Dr. Graham, he's the program manager of Life for a Child, and they're supporting since 2010. In Bangladesh, we have done some research with the Life for a Child as well, but not, of course, the randomized control trial.
Yeah.
So you see, this is, I should say, for Bangladesh, it is a milestone for doing this human versus analog insulin, that is HumAn-1 trial, and definitely BADAS will play a role, and obviously
you are now successful.
yeah, we should say that yes, we could, in spite of lots of challenges, yes, always, you have the local challenges and different country had different perspective, different type of problems, different culture. So, but you have to sometimes amend the culture. I mean, all the um, things like, as she will discuss about it, like qualitative study, other study, we had some quality of life challenges. So we have to translate in Bangla and whatever. So lots
There's
of
some
issues.
language
But
barrier
yeah,
as well,
exactly. So yeah. So you see, we have met all the challenges on our perspective, and ultimately we could finish it, and now it's going for publication.
Would you please specify what role did the Diabetic Association of Bangladesh and PDRC play in implementing this study?
Well, first of all, that this side is just, as has mentioned, that this has a unique center, I should say, with the good number of population of type 1 diabetes, a large number, one of the largest center we can claim, because almost now we should say registered are more than 9,000 patients. Among them, more than 70% are type 1 diabetes. So you can see almost around 7,000 patients are registered in our Pediatric center in Bedowra.
Okay. And what we think, most of the people are type 2 diabetes, but this type 1 diabetes is killing our young generation, right?
Yeah. So you see, type 2 is high prevalent. We have high prevalence in Bangladesh in adults, but type 1 is mostly in the
young
young population, yes, in the child, pediatric age group, mostly.
Yeah. Okay, thank you, ma'am. Dr. Jing Luo,
Mm.
how did the partnership with the University of Pittsburgh enhance scientific credibility and research standards?
Well, the University of Pittsburgh is a tier 1 academic research university in the United States. We're used to getting a lot of NIH funding. That's our large federal funding agency, as well as funding and support from other sources to conduct clinical research, basic science and discovery research. And so I think that is our reputation as an institution. And so that's something that we can bring to the table. In addition, we have a lot of we call it kind of like back office support staff, because in order to do the trial, we have to collect the data from participants locally, so in Bangladesh or in Tanzania, but all of the data has to be securely sent to our center at the university, to our computer systems. And we do all the analysis centrally. And so I think that is what we can bring and offer to this collaboration.
And what I know in your country, like in Western world, sample is very important.
Yeah.
Sample collection is more important.
Yes.
And this you maintain this ethical implementation very securely.
Yes.
That I know. And in in Western world, sample collection is very tough. Sample selection that is very common. It's easier for low and middle income countries, as I know, right?
Yeah, yeah.
So that's why you used to select these countries, right?
Yeah, like she mentioned, though, there's a number of reasons. One was
we have large population.
You have a large population of the participants that we are interested in. So when we set up the trial, we designed beforehand the specific inclusion and exclusion criteria.
Yes.
They have to have a certain age group. They must have never used analog insulins before. They must have never used a CGM before, a continuous glucose monitor.
Yeah.
And so that already starts to limit some of the sites and countries that we can select. Because, for example, we might go to a different country or a different center, but if 2 years before they have already started to widely distribute and use analog insulin, then a lot of those sites would not be appropriate for our study. So you kind of have to find this happy balance or medium between where patients don't necessarily have access yet to analog insulin, so they can be eligible for this study.
Yeah.
While at the same time, there's a lot of human resources and expertise and a very, strong clinical center where we can be confident that the team can do what we ask and also can complete all of the study procedures at a very high quality and a high level.
Yes.
So that's
it's a very good news for us.
Yeah.
Dr. Eimhin, I heard that though it's a clinical trial, but you added the qualitative method as well. Would you please explain about it?
Absolutely. So there were a number of sub-studies along with the trial. So I led a qualitative study, and there was also a quality of life survey and a health economic analysis. So the qualitative study was added in order to understand a little bit more about the context of Bangladesh, about the experience of living with type 1 diabetes for young people, their caregivers and families, and also the providers involved in delivering care for them. And we used the qualitative findings to understand what happened in the trial also. So a little bit about what worked for whom and why. And it allowed us to to contextualize the actual findings of the trial.
So what was your findings of quality of life?
The question was, what were our major findings from the qualitative study? So we did two parts. We did the first part before the trial to just understand the experiences of people living with type 1 diabetes. And the second we did during the trial, so to understand the experiences of having gone through the trial process. So in the first part, our major findings were really about the challenges that young people and their families face. There's a lot of issues around knowledge. So within the community, there's limited understanding of type 1 diabetes. Many people don't know that children can get diabetes and assume that it's type 2.
They think only elderly people can get diabetes.
Exactly.
Young can't get,
And so the diagnosis is often delayed, and people are often very ill. And by the time they reach a hospital and are diagnosed, then they face enormous stigma. So one of the people we interviewed said when they first discovered that they had type 1 diabetes, that they thought, I'm going to die, there's no point in living. So it takes a lot of adjustment for people. They initially have no hope. Families are very worried for the future and about their potential to get married, to have children, and so on. And they face stigma then in school, in the workplace. And it means that many people hide their diagnosis. They don't tell the extended family. People may not tell their in-laws. They certainly may not tell their school and their peers and their workplace about diabetes, because people assume that they can't function as normally in life and that they're not normal. That's one of the quotes that somebody said to us during the interviews. So then when the patients that we interviewed reach Birdham Hospital, which is an excellent multidisciplinary approach to diabetes care, then they develop hope. They understand what they need to do in terms of managing diabetes. And they're very lucky that they have donated insulin and monitoring equipment and an excellent team.
And they got counseling as well.
Absolutely.
Counseling is the most, I think, one of the most important part for them.
Absolutely.
As they got the stigma and they think many things about diabetes.
Exactly.
Which is not right.
So the health education, and there's also psychosocial support from a psychologist in the team, which is really, really important. And when they meet other young people who have diabetes and see that they can live a normal life, that gives them hope. And so those are some of the major findings from our first part of our study.
It was the first part, and second part, RCT was the second part, right?
So we did a second qualitative study during the RCT. So we interviewed people who were maintained unusual care with human insulin and others who were switched to the newer analog insulins to see if they had different experiences. And overall, everybody had positive experiences of being in the trial, even if they were in the usual care arm, because there were changes associated with the trial. So an intensification of education, introduction of home visits, which were related to the trial, and they were changed to pen devices as well. So people previously had been using glass vials, insulin syringes and needles to deliver the insulin, which is painful and can cause skin issues. And they were changed to these very easy to use pens, which have very fine needles and they're much easier to give.
Is it available in Bangladesh?
Well, that's an excellent question. Maybe that's a question for Dr. Bedowra.
Yes, madam.
Well, it is available, of course. The pen is available, but the main thing is that this analog insulin is expensive in our country. But for this RCT trial and also for the support, as we have mentioned, about Life for a Child, yes, we have our patients are now having some almost 1,000 patients are having free pens analogs from our center.
From your
our,
center,
yeah,
yeah.
with the support of Life for a Child.
So, dear ma'am, what about the other?
That's a
people?
that was our discussion, and
Yeah.
that was one of the reason of having this robust
Study.
evidence of study
Yeah.
for in these low middle income countries like Bangladesh and Tanzania, because in the developed world,
Yeah.
the most of the patients, all of the patients are using now analog. There is no human insulin.
No human.
But
insulin.
unfortunately, because that's more expensive one,
Yeah,
and
of course.
human insulin is cheaper one, so it's available in all low middle income countries. Analog is for the rich people, because of the cost. The poor people, no, they cannot afford
They
that.
can't
That's not
afford it.
the affordable one.
It should be free for
That's
them.
why we're having this RCT, and we're thinking we have to make some policy, of course, for the lower middle income countries,
Yes.
also for Bangladesh.
And we hope it will be free for all population. There will be no
Maybe one day it will take
differentiation of
time. Yeah,
poor
but
and rich people. Yeah.
we have to work on it.
Dr. Jing,
Yes.
how many study population was in this RCT? Or
Globally, we recruited we randomly assigned 400 youth
Yeah.
with type 1 diabetes to either standard of care human insulin or to our analog, the long-acting insulin analog that we were studying. Of those, 250 were in Bangladesh, 150 were in Tanzania.
but first you conducted in Bangladesh, then Tanzania.
The first participant
Yeah.
was recruited in Bangladesh, and then a few months later we started in Tanzania. So
Yeah.
they overlapped.
Yeah.
Bangladesh started first, Tanzania followed. Bangladesh did also finish first,
Yeah.
but Tanzania finished after, and we could not analyze the results and
So would you
report
please
them.
mention the study year?
Sure, yeah.
Yeah.
So we began, the first participant was enrolled officially in March of 2023,
Yeah.
and we finally finished around March of 2020.
October, ma'am said.
Oh no,
Well, no,
so
no,
that's
in-
the finish. That's
Yeah.
the March 2024.
2020.
in Bangladesh.
Yeah, in
But in
Bangladesh.
Tanzania,
In
we
Bangladesh,
finished in
but
February of
yeah.
2025.
But,
2025.
after
2025. As you say, 2 years study. Yeah. And what was the inclusion criteria, and which age group you involved in the study?
Sure. So the inclusion criteria were as follows. The study participants had to be youth between the ages of 7 to 25 years old when they entered the study,
So you covered child and young.
and young adults.
Yeah.
So children, adolescents, young adults.
Yeah.
Yeah.
And if they have any comorbidity, you excluded them, right?
Yep. So if they were pregnant,
Yeah.
if they had any desire to be pregnant
Yeah,
during
yeah.
the 1 year while they were on the study,
Yeah.
if they suffered from severe malnutrition,
Yes.
or if they could not provide informed consent, then they were not eligible for our study.
Okay. And what is your findings? Is there any gender discrimination? Did you find any gender disparities in this study? Like boys are more involved,
Yeah.
more, or girls are more involved with this? What do you think?
I think of the youth that we
Females.
recruited, about 58 or 59% of them were females.
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 So the majority were
So
females.
majority of our females.
Right?
Yes. Yeah, because in our population,
Yeah.
if you look into our population, yes, females are more than male in
They
type 1
affected
diabetes. In type 1.
Yeah. Okay. Type 1 diabetes.
And then in terms of the results,
Yeah.
we haven't spoken about the results yet, but what we found was that at 6 months, there was no difference for our two primary outcomes comparing these two types of insulin.
6 months, there
But,
was no difference.
No difference.
Yeah.
But then by 12 months, we start to see some statistically significant as well as clinically significant differences.
Yeah.
This time in favor of glargine insulin, which is the newer, more expensive insulin.
Analog insulin.
Yeah, and then your question about whether there were differences by sex, I don't think so. I'd have to go back and look at our supplementary tables just to make sure, but I don't think we found a major disparity by
Maybe
gender.
female were recruited more. That's why.
Because-
Is it possible,
But
madam?
because in our population, we
Yeah,
have
yeah.
more female, those who are
Yeah.
affected by type 1.
Yeah.
So, obviously in the trial also we got more female patients. Maybe that's the reason.
Yeah. Okay. Dr. Bedowra, how can the findings influence Bangladesh national insulin policy and essential drug list, ma'am?
That's a very significant and important question, because we had just had a roundtable discussion
Yes,
with
ma'am.
everyone, because we have the capacity. I mean, the BADAS has the capacity of providing insulin free with the international collaboration,
Yeah.
maybe from the government side or international national level, whatever. But main thing, yes, we need a policy now because, like, we are giving support. It will continue maybe till 2030. Till now, it is our, I mean, the agreement that Life for a Child will give support. So
Do
what
you
will
have-
happen after
Yes, ma'am.
2030?
Yeah.
Because we should start work on policy now. And
Yeah.
now we have a robust evidence. Yes, analog
Yes.
is better,
Better.
and having less severe hypoglycemia than the human insulin. So yes, now the importance of coming, I think, in the national policy, national guideline, we should introduce the insulin analog type 1 or other factors also, how to make this center sustainable, because after 2030 there will be no support from the LFAC, I mean Life for a Child. So what will
you
happen to
have
this?
that analog insulin support till 2030, right?
With
That I
human
can
insulin,
understand.
with also
With
human,
also
some
human
human
insulin,
insulin,
some
some,
and
yeah,
yeah.
from
But if health for all,
yeah.
if we want to make it generous, what do you think? What's your opinion? What should we do? Definitely, government should
Yeah,
come
government
forward because
government
only
should-
BADAS can't
No, it's not
work
possible.
alone.
Government came forward, somehow it stopped because in 2023 there is a policy, but maybe there is fund problem, whatever. Now it is stopped. Maybe we will, but us will definitely will
So you
again,
are
yeah,
struggling,
work
but
with
you are
it,
working.
and yeah, because we know that's only the another thing I should highlight here. It's not only the question of insulin, but also, I was talking about that. Everyone in the round table was talking that we need also awareness about type 1 diabetes.
Yes.
We need training of the healthcare professional. We need awareness in the community also. In the schools program, we should include, because the patients, most of the patients are going to school in one age, and then they are growing up. You say it's so important, but nobody knows about type 1. So that's another point. And at the same time, I think government can take step by step some policy, because it's not possible for government to take care all of thousands
No,
patients
no.
together. But maybe it will by year they can introduce in their budget. So some number of patients they can include 1 year, then next year they can increase.
And
the-
awareness should start from the family. If there is a baby, obese baby, we are shouting with her why you are having snacks, junk foods, and we should bring bring him or her to the hospital to check it. And awareness is very important for us.
Yeah, obesity it is another part, of course, because if a child is obese, there is every chance of developing pre-diabetes or type 2 diabetes. Yeah,
diabetes.
exactly. That's another point.
Huh.
But for this trial, we are focusing on type 1 at this
Type
moment.
1
That's
only.
another chapter. Yes, we should work with also obesity and prevention strategy for the type 2 diabetes as well in Bangladesh,
Yeah.
because it's rising at the same time.
It's rising as well.
Yeah.
Okay. Dr. Jing,
Yes.
what steps are being taken to make analog insulin more affordable and accessible? I think it's more similar question, but what do you think? What's your opinion?
You mean Bangladesh or globally?
In Bangladesh first, then
Sure.
globally.
So this was one of the topics that came up during our policy roundtable
Yeah.
that just happened immediately before this. And one of the ideas that was brought up is there a way either through importing insulin that is manufactured outside of Bangladesh to drive those costs down? That might be one way of doing it. But the second way is there a way to have local manufacturers, perhaps with support from the large established high quality insulin manufacturers, to be able to make high quality, very effective and convenient forms of insulin
Now.
here? Yeah, there is a plan. There is a plan from one of the large manufacturers to do
Now,
that.
who are the biggest manufacturer of analog insulin worldwide?
The largest manufacturers worldwide are either Eli Lilly, Novo Nordisk, or Sanofi. Those are the
Sanofi
three.
as well.
Those are the three major manufacturers for insulin.
Yeah.
They're called the big three because they produce something like over 90% of all the insulin that's used
Do you
globally.
think, if they are involved directly here, it can reduce this problem, or what do you think? Is it possible?
I mean, they're already part of this
Mhm.
solution
Yeah,
because
yeah.
you can't
They
manage,
already.
you cannot manage type 1 diabetes without insulin.
Yeah, yeah.
And so you have to go somewhere to obtain the insulin.
Yeah.
And so the manufacturers are definitely part of
Mhm.
the solution. Whether the costs can come down to a level where the
Yeah.
government or
Should
a
come forward.
non-governmental actor can help to provide all of these medicines, as
Mhm.
well as the commodities that are related to the medicines, like the vials, the syringes, the needles, the pens, the diagnostics, like the
Mhm.
glucometers, the machines, and the test
Yeah.
strips. Whether that is affordable is a big question.
Yeah,
But
of course.
that's something that I think the policymakers and the people in Bangladesh will be that problem they'll be working on for many years.
Yeah.
Yeah.
AB, how are you?
Good. I'm Dr. Abby.
Dr. AB, how are you? How was your experience as a project manager of this clinical trial?
It was a wonderful experience. I got to meet all of these wonderful people in Bangladesh and Tanzania, and also our other international partners. It's been a wonderful learning experience to learn about all of the challenges and all of the different needs that are available,
Yeah.
that are happening here.
And what's your experience about this Bangladeshi population, like especially this sample? They were cooperative. How was your experience about this?
Well, they were wonderful. A lot of the youth that we deal with at the Burdham Institute have a lot of respect for all of the doctors. That's a nice thing that is wonderful to work with this population, and they trust their providers here, which has been
Yeah.
very nice. So I think they were a little scared about the research. They were fearful about, being experimented on.
Yeah.
So we had to be very careful about how we presented what the plan was for the research study. But after they understood what all was happening, and the fact also very importantly that these are not new experimental drugs, I think they were much more comfortable. Again, I think it cannot be said enough how comfortable and how much the providers at the Burdham Institute are helping these young people and making them feel welcome and supported.
So it was your first visit during this research in Bangladesh?
I'm sorry, what's the question?
So it was your first visit.
I've been
in
here.
Bangladesh.
This is my fourth time here
Fourth
with this
time.
research study.
So
yes.
it was your research purpose or other reason?
Yeah, my job is I work with Dr. Jing Luo, and I am the project manager,
Yeah.
which means that I help work with the partners here in Bangladesh and Tanzania,
Yeah.
and also the other partners to try to make all of the research happen. So that's my role.
It was
in
a
the
very
study.
tough job. You have to travel a lot during the research, right?
Yeah, there was some travel, but lots of meetings, lots
Yes.
of emails, lots of communication.
It's a
Trying
big coordination team,
Yes.
yeah, that
all
you
about
have
coordination.
to do.
Yes.
Yeah. Thank you so much. Dr. A. So what implication and study findings for the model of care you found?
We talked already about insulin access and
Yeah.
how analog insulin access could have benefits as long as it's affordable and accessible to patients. But we've also talked about how they need to have the delivery devices like pen devices, because they have huge benefits in terms of decreased pain, more self-efficacy, so people can actually manage their insulin themselves when they are using those devices. But they also need the monitoring equipment. So they really need the glucose meters, the strips and the lancets, and all of those need to be packaged together. But without having the support of the doctors and the wider multidisciplinary team and the very intensive education that goes along with it, those things are almost useless. So what's really important about the service that Dr. Bedowra and her team delivers is the intensive education and the psychosocial support along with all of the medical and clinical advice.
Yeah.
For now, that is all very focused in Dhaka, and it's very difficult for people who live far away in rural areas to access that care.
Yes.
First of all, to access diagnosis, because the knowledge is not there often in the peripheral areas of Bangladesh amongst the clinical teams. And second, once they've been enrolled in the Burdham services, for them to access and travel to have their regular follow-ups and checkups. So one potential solution is to try to decentralize some of that care,
Yeah.
so that medical teams that are outside of Dhaka will know about type 1 diabetes and know how to manage it.
Yeah.
And also to use things like digital technology so that some of the expertise that's here in Dhaka can actually reach people who are far away, because it can be done remotely using video calls or using other forms of digital technology. So training and upskilling staff is very, very important. Trying to package the care and bring it out of the center and into the periphery. So towards, primary healthcare, for example, is very important. And then a key element of that package of care needs to be the mental health and psychosocial support, and ideally developing things like peer support.
Yes.
And so that people have that understanding and the hope, and also that it improves their quality of life.
Yes.
I think those are really key.
So all doctors, nurses, medical technologists, they should know about type 1 diabetes. They should know how to differentiate type 1 and type 2 diabetes, and they should have the training. Right. Thank you.
Yes.
Thank you so much. Dr. Abby, beyond medical data, what social or psychological insights did the study reveal about young diabetic patients?
Yeah, there were many things that I learned. First of all, I had not known very much about Bangladesh culture earlier. So this was, a wonderful learning experience. One thing that came to light, as Dr. Eimhin earlier mentioned, is the matter of stigma and how much that young people really are reluctant to reveal their status as having type 1 diabetes, and they're fearful that it will negatively impact their lives in multiple different ways, things like possibly getting married or being treated differently in school, or among other family members or in their community. So that was something that was new to me, to learn that was something that the youth were dealing with. And as the study has progressed, and we're still thinking about now, how do we help these young people deal with this stigma situation?
Thank you so much, Dr. Jing. WHO has a list of essential drugs.
Yeah.
So what impact it will bring this clinical trial?
It's a good question. So the long-winded answer is that long-acting insulin analogs were added to the essential medicine, the WHO's model list of essential medicines in 2021, after failed applications in 2017 and 2019, because there wasn't enough evidence of efficacy in the real local context in low middle income country settings. And so when it was finally added in 2021, members who were sitting on the expert committee who debated the application and its ultimate inclusion, they were really concerned that there wasn't enough high quality trial derived evidence from the local contexts. And they were also really concerned about affordability issues and the fact that the analog insulins were so much more expensive, and it would cause budgetary concerns in LMIC countries. And so even though that class of medications was added in 2021 and our study wasn't completed until 2024 and 2025, I think it will really help countries, especially from low resource settings, think more actively. Yes, this class of medications has been recommended as a model essential medicine to meet the priority public health needs of large populations. But now we finally have the evidence. I have the data from South Asia and from East Africa. It's much harder for them, for policymakers, for people who purchase insulins, to say, oh, we don't need to make a decision on that because we don't have the evidence.
They can't deny it now.
It's much harder to deny.
Yes.
That's my opinion.
Okay, Dr. Bedowra, madam, would you please tell us about this RCT, the states, and what was the final findings? We will conclude it.
Well, as we have mentioned, that we have started in 2022. The Bangladesh site I'm just talking about. For the screening process, we screened like 1,024 patients. That was ended in next year, that is 23, and then we first recruited patients in 23 March. That is probably 15 March. That's the first patient randomization done. So finally, if we want to talk about our primary outcome was to look into, because for the type 1 diabetes, always we are aware or scared of severe hypoglycemia. So, and the primary outcome was that we have to see that the both arms, because we are talking about human insulin and then analog insulin. So, whether there is difference between the severe hypoglycemia in two arms, and as because it's done in already in the developed worlds, but we have mentioned that in the lower middle income countries, this was the first study, and interestingly, we got the same finding like the developed world. That is, yes, in the analog arm, there is less severe significantly less severe hypoglycemia compared to human insulin. So you see, this was our primary outcome. There is other, because what we know about HB1C, we always go for HB1C and others, but main part for the type 1 management is hypoglycemia, severe, especially severe. And yes, we got that. It was significantly low
in well managed
in
by
analog.
analog. Okay, ma'am, what do you think? Could this model of Bangladesh research be replicated in other low or middle?
Well, because we haven't focused in this interview, it was not possible to mention. Actually, we are talking about the results, but how many, like Abby and Zing and all say that how many hundreds of mails, 100 of Zoom meeting, and the physical and virtual training of the research team, and recruitment of research team first was a challenge, and then research team training, everything, then patient management, new thing, innovation, everything. It was a great challenge for us.
How many members were in your research team?
Well, in the research team, there was one trial coordinator, myself, then as local PI, and then we had 5 research assistants. But there was also educators who were giving us education. That's the clinical part, and one physician, one psychologist, and dietitian. Yes, we had the support.
From our excluded the pregnant ladies from
the
study.
That was our
exclusion for the for clinical purpose. Is it safe for pregnant women analog insulin? Is it
some analog insulins are safe, but when we did the study, that was not, the glargine was not, but now it is approved. We can use in pregnancy, but at that time it was not approved. That's why.
So during this pregnancy, what will they do? They will use.
Well, we are not. No, they can use another, because we have another type. Yes, analog is, of course, you can take in pregnancy.
Okay, so we are at the end of our program. So, Eimhin, would you please tell something for us? What was your overall experience in Bangladesh and this clinical trial?
I mean, it was a wonderful learning experience, as Abby has already said. I think we have to emphasize what a fantastic team Dr. Bedowra led, just the hard work, enthusiasm, energy that everybody put into the study, and the kind of, more than that, the devotion. The team is very committed and compassionate, and does everything for their patients. And one quote that I presented earlier during our presentation of results, one of our interviewees, a patient, said, "My doctor is like a second mother to me."
Wow.
So I really think we need to emphasize not just the care, but also the compassion and the energy and the commitment that all of the team here have put into this study. And it's been an absolute pleasure and a privilege for us to work with them.
Thank you so much. Dr. Jing, my last question will be quite different from her. So, what message does this trial send to global policymakers about equity in diabetes care? What do you think?
Well, I think the message is this. For the longest time, people have thought and have tried to justify or argue that it's okay for patients living in high-income country settings to have the access to the latest insulin, to the most expensive and most helpful and convenient diagnostic tools, artificial pancreases, automated insulin devices, and that people who come from, who happen to have the bad luck of being born in a less resourced country, in a poorer country, should not have access. And that is an okay world that we live in. But I'm hopeful that our study can help to contribute and fight against that kind of belief, and to say that that type of thinking is fundamentally unfair, it's unjust, it's inequitable, and it shouldn't exist anymore. So
Thank you so
yeah,
much.
I hope we can have more equitable access to
Yeah.
health technologies and products.
Thank you so much. Dr. Ivy, I hope you have a very nice experience from Bangladesh. What do you think?
It is a wonderful, lovely place, much more than I ever would have imagined. The hospitality of everyone, especially Dr. Bedowra, has been wonderful and a pleasure.
And definitely, it's a very nice and appreciable project that was conducted in Bangladesh. And we are really proud that we are the host country of this research, ma'am. What do you think?
Yeah, of course. Yeah, of course. This is a pride, of course, that we can at least now we can say that yes, we could do the first randomized control trial in human bus analog insulin in Bangladesh as a lower middle income country, and definitely we have learned, of course.
Yes,
Yeah,
ma'am.
it's a great learning for all of us, and definitely we can now say yes. We have a now
can
model.
conduct our
Yes, we
city,
have model. We are confident now
Yes.
with our team. Yeah.
Ma'am, you were talking about some challenges. Would you please tell us in short about these challenges and how would you overcome it? I need to know.
Oh,
please.
yeah, that's okay. Because I have shown in my presentation
Yeah.
that, the challenges was, the first of all, to find a research team. Don't you
Yes.
think it's a challenge in Bangladesh?
Of course.
Yeah,
How
people are
many
not aware.
researchers
Yeah,
here?
exactly.
They don't like research.
That's what the recruitment
yeah.
process was
That's
one
very tough.
challenge. And then we got a good research team and then we did them training, whatever. And then challenges come from the patient side
Yes.
because, everything, first of all, there is a confusion about research.
Yes.
They think, okay, you will experiment on
You
me.
don't
Yeah,
be-
what do you want to go, doctor? Is it okay? This insulin is okay. This CGM, what is it? You are going to introduce
They're
yourself.
giving us
Yeah,
free? Is it
exactly.
okay?
So so what we did also, we did the CGM on ourselves as well, all the team members. And that was because we had to have the experience as well.
Yes.
So you see, this is so very important, what just Eimhin was saying, that actually we had lots of challenges like traveling. That was a real challenge because most of the patients are outside Dhaka. If you could see the video, you can see how there was flood, there was difficult to go, and lots of challenges came, whatever. But if you have a dedicated team,
Yes,
if you
yes.
have the compassionate team,
Compassionate team,
and
yes.
dedicated team, yes, you can do that. You
Ma'am,
can
what's the
overcome the
next step
challenges.
now?
Well, the first of all, we have done the whole day. We have
Yes.
did the programs. We had the roundtable discussion with the stakeholders, with the government, with the non-government agencies. Now, yes, we should approach the national guideline, national policymakers.
Yes. Thank you, sir. Thank you, ma'am. Thanks for your valuable time. And thank you to all our honorable guests for joining this meaningful discussion on the HumAn-1 clinical trial on type 1 diabetes in Bangladesh. Dear audience, stay healthy, stay safe, and always keep some knowledge about type 1 diabetes because awareness saves life. Goodbye. See you again.